So we've talked about TKIs, PD-1 inhibitors. Let's talk about vaccines. There are a few in study. Nizar, do you want to talk about the ADAPT trial?
Sure. I think, the two phase 3 trials with vaccines that have been recently conducted. One was presented at ECHO this last September by Brian Renal, and it had both phase 3 trials with the vaccines, although they're using different vaccines, had similar design. Sunitinib as a comparator versus the experimental arm of sunitinib plus the vaccine. The difference in the vaccine between the two trials is that the IMA 901 trial used an off-the-shelf tumor-associated peptide vaccine. They gave it to all the patients, and it was so the primary endpoint for both was survival. The IMA trial was negative. It did not show a survival advantage for this tumor-associated peptide vaccine in combination with sunitinib. The ADAPT trial is using a patient-unique vaccine taken from patient's own kidney, where at the time of nephrectomy, the specimen is harvested, vaccine is generated, and it's a dendritic cell-based vaccine that's RNA. So it's an RNA vaccine in combination with sunitinib. So the trial finished accrual this past summer. It's somewhere around 450 patient trial. We'll see what the results will be. I think they're not anticipated before 2017. So again, primary endpoint is OS. I hope it will be positive because there'll be another opportunity for our patients to use a patient-unique vaccine. But we'll wait and see if the results will be positive.
So obviously all vaccines are not the same. So you really do need to look at the specifics of each vaccine rather than making decisions about all vaccines. But we've now got two negative large phase 3 studies in renal cancer with vaccines, because it's not just the most recent one. There's the Trovax vaccine from years ago as well.
That's right.
And there are, in other cancers, there are a number of large negative phase 3 studies. And the bottom line, it looks as if, when you're dealing with diseases that have the potential to be controlled by the immune system, if you suboptimally try to activate the immune system, you may be inducing anergy or non-responsiveness in those tumor lymphocytes. And patients do worse. And actually, I'm wary now about considering trials of vaccines on their own without some really robust data that makes me feel comfortable offering patients, because there aren't many settings where we're randomizing patients where we've got some historical data implying that if we're not careful, patients may do worse than with standard of care. And so I think the role of vaccines increasingly is probably going to be with combinations and taking some of the more highly active immunotherapeutics and seeing whether we can increase the bar of those with vaccination. I think that's obviously where the field is going to be going.
Another important concept in that line is the fact that vaccines are directed to a specific antigen, okay? And in an evolving disease, a heterogeneous disease, we cannot guarantee that that antigen will remain as an active part of progression of the disease. So it may work to a certain clone or at a certain time in treatment evolution, and not necessarily at the end. So the combination certainly is a good concept when you applied it, and I agree with you that the data in general with vaccines has been not very impressive so far.
Carlos, do you want to talk more about the combination trials? So now checkpoint inhibitors are also being combined, and even with TKIs. Can you comment on those?
Certainly. The idea of Nizar was presenting the data of the combination of the anti-VEGF and the mTOR inhibitor as the first time over the last 15 years that we have been able to target both pathways in that regard. So this has been a concept that has been clearly established in oncology in general. We manage complex and heterogeneous disease by targeting different pathways at the same time. And routinely, or in most cases, we found better results. So this concept actually leads to the fact that if we have single agent activity with immunotherapy, single agent activity with other targeted agents, the idea is to combine them. The problem has been the fact that not necessarily all these agents have been able to combine with each other because of toxicity. The point in the immunotherapy era, and as we mentioned before, the trial that compares sunitinib as a first agent, as the first line, with the combination of nivolumab and ipilimumab that has been proven effective in other tumor types, in melanoma, it's obviously a very important step forward. Whether we can combine with this combination other targeted agents obviously is something we still don't know, but there remains a lot of interest in that kind of situation. So far, the combinations of immunotherapy as single agents with targeted agents has been very preliminary with some results. We don't know what the best dose is. We don't know the toxicity, and some of the initial trials have been very complicated to analyze. I think it remains a subject of active investigation, and we should pursue further this kind of line of research, although I would encourage everybody that is doing this to collect biological material in order to rationally develop this area.